When you're designing a therapy for a patient, you tend to think, what will I give first, and then what could I give later as a second or third line option? But you always want to use your best therapies first, because you never know what will happen. You might think, oh, I'll just use immunotherapy as my next line of therapy, but we know that a lot of our patients, maybe 40%, never make it to that next line of therapy. In non-squamous, non-small cell lung cancer in a first-line setting, these days we tend to think about immunotherapy as an option. And is a patient a candidate for that? Can I give, for example, pembrolizumab alone as a first-line option, knowing that chemotherapy would be a next line of therapy for that patient? For squamous non-small cell lung cancer, immunotherapy is still an option up front. We don't have the same kinds of options in terms of targeted options that we think about in our non-squamous patients like EGFR, ALK, and ROS. So our options really come down to immunotherapy or chemotherapy first. And we may be finding out here in the next year that chemotherapy and immunotherapy makes sense in the first-line setting. The bottom line is when you're designing somebody's first round of therapy or first-line therapy, you always want to use the best therapy you have for the patient and not save therapies for later lines of therapy, because you may never get there.
The indications for therapy and the determination of therapies for advanced lung cancer obviously is going to depend on stage. Whether it's combined therapy with radiation therapy, chemotherapy alone, whether you're introducing the immunotherapies up front or they're considered as a second line therapy. All those decisions, I think, are based obviously primarily on stage. They're going to be based on the patient's condition. Can they tolerate one or more of these therapies? And I think importantly, they're also going to be based on, and they should be, I think, in many cases, if not all cases, they should be based on determinations at a multidisciplinary tumor board, where all the information is then available and the input from all the different specialties, surgical, radiologic, radiation oncology, pathology, medical oncology, can combine, I think, to provide the best therapeutic options for the patient.
So it's actually very important to manage the side effects in our patients because it enables them to stay on treatments longer. If you don't do that, then very commonly you encounter dose reductions or dose delays, and that's pretty suboptimal for the patient's treatments. So it's important to bear that in mind and educate the patients so that they know what to anticipate, and also that they report these toxicities early enough so that you can treat them quickly.
Quality of life has always been a really key component of cancer treatment. Whenever I'm talking with my patients, we talk about everything that we're doing is either going to be focusing on helping them live longer or helping them live better, and ideally doing both at the same time. And so as we have had more and more improvements in outcome, more people living longer, we are paying even more attention to side effects of treatment that could be debilitating, and also on working with patients to make sure that they're able to enjoy life as much as possible.